So today, our program is on preventing suicide in senior communities and promoting mental health as we do that. I want you to know that these programs are directed for independent living, assisted living, skilled nursing care, nursing homes that is, and also I believe that we're touching a lot of home health agencies and senior centers. So we hope that as you answer those surveys, you tell us other programs that you would be interested in as we move forward. Why is this topic so important? It's interesting to me that I was in a meeting this week and one of our board members asked, why are we presenting on this topic? And I think that it is significant to know that this is a much bigger problem than any of us actually know about. When you work in long-term care and in continuum of care for a long enough period of time, you can hardly work in a facility that has not experienced a suicide. But if you haven't, we are so pleased, but we know what the national averages tell us. Older adults die by suicide at a much higher rate than the national average of people. And we're going to talk about that and the reasons why in a few minutes. And the rates go up significantly after the age of 65. In addition, when older adults attempt suicide, they are more likely to die. They are successful in their attempts. So why is this topic so important? Because of those three reasons. What do statistics tell us? Well, 1 out of every 4 older adults who attempt suicide dies. And 1 out of every 100 to 200 younger adults who attempt suicide die. Look at the difference in comparison. That goes back to they are more successful as they're older than somebody younger, and a lot of reasons for that. But those are the statistics we know. Some statistics that we're missing are there any reliable statistics on whether suicide in senior living communities are higher or lower than those that are living in the general community? And we don't have that knowledge at this time. What we know is that residents in senior communities have many of the risk factors that are associated with suicide, and that is depression, social isolation, a lack of a sense of purpose in their life, of course illness and pain as they age, and family losses. When we talk about family losses, I want to interject here, that doesn't mean just spouses, because many older people today that are in their 80s or 90s are losing their children who are in their 70s. So these are some of the risk factors, and we'll go into these in depth. Our responsibility. There is no question that it is our responsibility to understand that we have the opportunity and responsibility to prevent suicide and other self-destructive behaviors. And I really want to point out to you that in senior living communities, we can do this without creating a lot of new programs or having to hire a lot of new staff. And that many times is what people perceive as the barrier to making changes or implementing things within their facilities to help prevent suicide. This full program is brought to you, and you can take down all this information and go back later. You can call us or email us at info@mmlearn.org. But this book I was able to find at a national program by Leading Age, and this was given to those who attended the session. An amazing piece of work that's available to you for free that has the entire program that we're going to talk about today and way more. But I think this is a starting point for you, but you need to know the materials that are out there and that are free for you to use to implement programs yourself. But I hope this one helps you even more. So let's begin with some definitions so that we all know what we're talking about. Suicide is a death from injury, poisoning, or suffocation where there is evidence that a self-inflicted act led to the death. I think we're all pretty familiar with that definition of suicide. A suicide attempt is when there was a potentially self-injurious behavior with a non-fatal outcome. And there is evidence usually that that person intended to kill himself. And it may or may not result in an injury, but the intent was there. So that's a suicide attempt. Some of the words we don't always know about is something called suicidal ideation. And this is when it says self-reported thoughts about engaging in suicide-related behaviors. Doesn't necessarily mean somebody is calling up their doctor and saying, I have this idea. Suicidal ideations can come out at a dinner table, can come out in the library, in a group of people talking, just saying, my life would be better, my family would be better off if I wasn't alive. I would be better off dead. I just as soon kill myself as to live like that. Those can be indications that people are beginning to think about suicide or planning suicide, and these are thoughts about engaging in suicide-related behavior. And then we have what is called passive suicide, and we see this more likely in long-term care facilities and some in assisted living, but they also call this indirect suicide, and this includes behaviors that occur that can result in death that are a refusal to eat or to drink or to take medications or to follow treatment plans or to take unnecessary risks. So that's called passive suicide. Passive suicide is so important for you to understand is different from an end-of-life decision. And we get confused about this a lot, and it brings up many ethical considerations for people who work in assisted livings and long-term care. But I want to be very clear that an end-of-life decision that's made by a terminally ill older adult in which they've implemented a healthcare team to support them and they've rationally thought out the decision by themselves and with their treatment team to not use certain medications or to withdraw a certain type of treatment is not suicide. So passive suicide is very different from end-of-life decisions. Studies. There are no current studies that demonstrate the rate of suicide is higher in senior living communities than those not. We mentioned that. But there are several studies that have shown that suicidal ideation, which we just talked about, and depression, which is one of the major risks for suicide, are more common in residents that live in nursing homes than those that do not. So we do have those studies to help guide us and make us understand why this is so important for us to address this issue and not ignore it. What are the most common methods of suicide? In older adults, the CDC, or the Center for Disease Control, in 2006 was able to demonstrate that firearms are the single most commonly used item by older adults for suicide. And this is more frequently utilized by men than by women. In nursing homes, however, though, jumping from high places, hanging, and taking overdoses of medication and cutting have been cited as the major reasons. Now, I want to mention here about, because it's so important with the overdose of medications, if you think about in a nursing home, how could they do that? That might be when the nurse or the med aide does not stay with the resident long enough to see them take all their medication. They're hiding the meds, putting together a amount to be able to inflict harm or to kill themselves. So important that we understand these common methods and some of the things that we can do, and we're going to be talking about that. Older adult population suicide attempts are more likely to result in death, and that's because older adults are known to plan more carefully and use more deadly methods such as guns. Now let me point out to you that older adults spend a lot of time planning. Young people are very impetuous when they do that, and that's one of the reasons they may not be as successful. Older adults are less likely to be discovered and rescued than younger people. And finally, many older adults are physically frail, and they're more likely or less likely to recover from a suicide attempt than a younger person would be. So this is why we see much higher attempt rate in death related. So what we're here to talk about today is identifying those risk factors and finding out what we can do to make a difference. Risk factors are simply personal characteristics or life circumstances or those particular situations that lead to or end up resulting in a suicide. And people with one or more of these risk factors have a greater potential for suicide. And this doesn't have just a limit to age. This could be even one of your coworkers. So these are just some things that we need to be thinking about and always aware of, but our responsibility, remember, as we work in long-term care or working with seniors. Please note before we start that just because someone has a risk factor doesn't mean we can change them. There are some things such as a previous suicide attempt may help to identify that somebody's more vulnerable, but that doesn't mean that we can prevent that. And we can't change all risk factors, but some we can. We're going to go through these relatively quickly, and then I'm going to spend a little bit of time on these as I see that where we can truly make a difference. But in illness with risk factors is depression, mood disorders, and psychotic disorders. And people who had mental illness when they were younger, it's not going to go away because they're older. And when people are older, they don't get depression just because they're older. Depression is not normal. Substance abuse and misuse are other reasons and risk factors. Alcohol, prescription, and over-the-counter medications are often ignored, but they are potential for causing death as well if they're abused. Physical illness, disability, and pain. Poor physical health, functional impairment, again, pain. The side effects of some medication can make somebody more susceptible or at risk for suicide. And insomnia. I can't talk enough about the importance of sleep. mmlearn has a full program, a 1-hour program on sleep and how to increase the ability for somebody to be able to develop better sleep patterns. So I would encourage you, if you see this as an issue, to look at that film as well. Personal and family history of suicide. Previous suicide attempts increase the risk for another attempt. And a family member who has died by suicide raises the risk factor for an individual to be susceptible or to have a risk factor for suicide. Current life circumstances. This is probably one that we have the most control over if we do, and that is social isolation. Major transitions, such as moving to a new setting. We deal with that every day with residents moving into our independent, our assisted living, our skilled nursing. This is every day. These life transitions put people at risk in their current life circumstances. So as we go through and learn some things that we can do, helping people to transition in, having ambassadors to help people are all things that we want to consider. Family conflict and loss. These are risk factors. If you hear that somebody is fighting with their husband or their children are fighting over their inheritance or these are things going on, these are all risk factors that can't be ignored. And when they're telling you about their family conflict, this is something that should raise our antenna to be listening. And especially we see so much loss. As I just mentioned, it can be their children, their spouse, and above all, their friends and their neighbors. And this is something that we have to recognize as a risk factor. One we commonly miss is financial problems. So when someone comes and tells us that they're not able to afford to live in our facilities anymore, or they're at a senior center saying, I can't afford assisted living, but they're telling me I have to leave my home, these are putting people at risk. These are concerns that we need to address. Current life circumstances is a lack of a sense of safety. Losing autonomy, respect, and supportive relationships and participation in activities we are going to talk about, because bingo doesn't fill this need. We will talk about some things that do. But this autonomy and respect, we have a lot going on in our culture today where we talk about ageism, we talk about issues of aging, but I want you to know, I think when we talk about respect and autonomy, we often miss the mark with what we're doing in our facilities and programs. Another one that's very interesting that I really found important to look at is other people have a lower expectation for them. They don't think they can do quite as much. Very interesting. So I think that we need to recognize how do we make people feel useful and needed, and we're going to talk about that in just a second. Some personal characteristics that happen are inability to adjust to change. These are personal characteristics that create risk factors. A low rating of their own health. I'll give you a perfect example of this. When someone is told that they have dementia or Alzheimer's disease, that puts them at risk. They need a lot of support during those periods. Or they're told that they have a disease that has the potential to be a terminal illness. That raises their risk factor for suicide. Low self-esteem, hopelessness, those are comments that you hear over the dining tables. As I said, in all the facilities, those hopeless remarks like, I have nothing left to live for. I have nothing that I can do. I can't see anymore, so I might as well not live. Something we don't always think about as a risk factor for suicide is impulsive or aggressive behavior. And those are behavioral changes that you see. People that all of a sudden never pushed other people. They were never aggressive before, but you begin to see them pushing to get on the bus or shoving someone in the hallway. Those are risk factors. Those are personal characteristics that we need to be looking at. And then cultural or religious beliefs that are favorable to suicide, an entire program in and of itself. And we have some good programs on that as well. Access to a means of suicide. Wow. Jumping from buildings. How do we protect and have areas where residents can't do that? hanging, cutting, and then taking overdoses of medications are all access to means of suicide, another risk factor. So, protective factors. What are those things that can help prevent suicide? I want us to know that there are things that we can do, and some of those actions can be taken by us as staff that are in these senior living communities. We need to recognize the importance of friends and family members. And most of all, I think we're going to talk about the role that residents have themselves to help one another. And there's so much to this program on suicide that we're not going to be able to nearly cover all of it today. But without a doubt, we will have future programming on this. But how do we involve everyone in this action? So what can we do? What can we do? Well, I think the first one is exactly what you're doing today, and that is making the staff aware and the interventions that are available. And the first one that we need to know are what are the key symptoms of depression in older adults. Depressed mood most of the time, sad, empty feelings, those are signs of depression. Somebody who wasn't sad and empty before. The loss of interest or pleasure in activities. Are we really watching when people were active and came to activities and now are staying in their apartments and not joining in? Are they having too much or too little sleep? I can't put enough emphasis on this. Again, we have programming on this, and I encourage you to watch our program on sleep. Know the key symptoms of depression in older adults also includes weight loss, of course, but many people don't think about weight gain. So many times in nursing homes you see that somebody doesn't fit into their clothes anymore. It may not just be just the simple fact of a higher caloric intake because of what we're serving. It may be that they're eating a lot more because they're depressed. Lack of energy is a sign of depression. Feelings of worthlessness. And that one makes real good sense, but extreme guilt sometimes we miss. When you hear somebody belaboring over and over, they wish they had changed things. They wish that life could have been different. They wish that they hadn't done this with their daughter or this with their son. Those are some things that mean we need to recognize that those are symptoms of depression and we need to take action. Difficulty with concentration. Sometimes hard to differentiate from a dementia, but something to definitely look at. This one is very important as a sign of depression, and that is noticeable restlessness. And this is interesting to me because I used to do a lot of quality assurance and would come in at all times of the day or night into facilities. And it was always amazing to me if I got to a facility at 4 o'clock in the morning that there would be people out walking around and seeming very restless. That to me is a sign of a potential for depression, which puts somebody at risk for suicide. What we need to remember is that depression is a treatable disease. So my question to you is right now, who is it in your facility that's designated for the staff to report if they recognize a resident is showing these signs of depression that we just went over? It's great that we train our employees, what does depression look like, what should you report, but do we know who to report it to, and is that person trained to do something with it? So the first question I'm going to ask you today is, after you go through this program with your staff, ask your staff who they would report that to. This isn't just nursing. This isn't just a certified nursing assistant who sees something to bring it to a nurse. This is somebody in independent living. Is if the housekeeper is in a home and has a feeling that this person is becoming more depressed, who is it they're supposed to report that to? If they're in dietary, if they're in activities, if they're just the bus driver, who's more important than anybody in most of these situations, who do they take this to? So the first thing for you to do at the end of this program is identify who is the person to bring that concern to. Depression screening in long-term care and assisted living is available. Nursing homes are required by the MDS, or the Minimum Data Set 3.0, to do this with all new residents and then periodically as required. There's also global depression scales, patient health questionnaires. The Beck Depression Inventory is an excellent tool, and of course the Cornell scale for depression for residents who have dementia. If you have independent living, you can't go around offering these depression scales and do screening willy-nilly with our residents, for sure. In nursing homes, like we said, we're required to do this. But on the other hand, I want to say that if you were to bring someone in for a conversation about health, to bring them in and talk about depression and then offer screening for folks privately, this is something that can be done, and we have lots of ideas for you on that, and they're included in the tool book that I showed you earlier, and I will address at the end. But know that there are many good screening tools that can assist us in determining if somebody really is at risk and be able to get them treatment, because it is a treatable disease. Just because someone's older doesn't mean that they don't have substance abuse problems. Truth is, sometimes the substance abuse problems are even greater. And diagnosing alcohol and medication abuse can be very difficult in a senior population, and most difficult in senior centers and in independent living, where we don't have control over what they buy, what they're bringing into their home. Many of us don't know that there are limits, or their sensible drinking limits are different for older adults than when they were younger. I have to tell you, I'm 61 years old, and I can't handle alcohol the same way I did when I was 21. I can tell you, I can have 2 glasses of wine and get a really good buzz. And before, 2 glasses of wine wouldn't faze me. So I do know that aging changes our ability to drink, and our limits change. So what are the recommended drinking limits for older adults? Older adults can drink low amounts of alcohol and drink infrequently and still experience problems. So for someone who's over 65, and this is the same for men and women, it is recommended that drinking mean no more than 1 alcoholic drink per day. This brings up a lot of issues for programs and activities that we have for older adults where we serve alcohol. And I know in every facility there is the dilemma, are we going to serve alcohol? Are we not? Is it going to be real alcohol? Is it not? That's going to go on forever, and I'm never going to end that debate. But what I can tell you is that we have the responsibility to limit the amount of service of alcohol when we're in our facilities. No alcohol for older adults should be given for people who are on prescription pain meds, sleeping pills, or meds for anxiety or depression. We know that alcohol will potentiate those medicines, and that increases their risk for depression and their risk for suicide. And in some cases, it can just be an unintentional overdose because they are not aware of the combination. You might ask me, well, if we're in independent living or skilled nursing, is this something that I have any control over? Well, independent living, if they're bringing in their alcohol, likely not. But the other thing is, we've learned so much about education. And are we educating our residents? And if we're not educating our residents, how would they know that there is that opportunity? And so we want to continue to have programs and groups and in a positive demeanor that allow people to learn about what they can and cannot do for their own well-being. So what are some signs and symptoms to watch for in alcohol? One of those is withdrawal symptoms when the alcohol is removed. And you might see tremors, you might see more agitation, sleeplessness. You also, another sign to watch for with alcohol abuse is increased tolerance for alcohol, that they're drinking more and more and they're not feeling it. You can always note that slurred speech. And then, of course, there's dehydration and malnutrition, and that's where people are using alcohol as a substitute for food, and they're drinking primarily alcohol. So they are getting dehydrated. Those might be some signs and symptoms to watch for. Some other symptoms to watch for are people who deny that they're drinking, or persistent irritability when asked about the alcohol. And they are going to be irritable usually when you ask about alcohol. They may hide alcohol. They might neglect their home or pets, or have changes in their personal grooming or hygiene. And who are the people who are going to see this? It's going to be the housekeeper seeing the hidden alcohol. It's going to be the people who are out in the communities that know that they're neglecting their home. Again, the housekeepers. And changes in their grooming and hygiene can be any single one of us. And that's why every person on our team, every person who works with seniors, needs to be aware of these signs and symptoms to look for. When you do address alcohol or substance abuse, be gentle, be caring. Recognize that this is not a comfortable issue for anyone. Be discreet. Do not bring this up in front of other residents or in front of their families initially. Be specific, using words like, I've noticed, or I'm worried because. and ask them for agreement on important points. Do you agree that? And we have some wonderful ideas for this in this toolkit as well, but just not enough time to go into every one of them. Activities, activities, activities to promote emotional health and well-being. Social activities often are not aimed at men, and if men are at a higher risk for suicide, we should be placing as much emphasis on their social activities. And I have to tell you, I've been in this field for over 20 years, and I have seen a number of suicides in facilities where I've consulted or worked. And I want you to know, in every case, it was a man. And I've often wondered, were we meeting all their other needs? Activities to promote emotional health and well-being continued is there is a demonstrated need to offer stress reduction activities and to promote discussions or presentations that affect stress. It's very hard to get people to come to a program on alcohol abuse. People are not likely, if you put up that today we're going to have a class on abusing your medications and alcohol, but they would come to a class about stress and reducing stress, because that's an acceptable thing in our culture to have stress, but it's not acceptable to abuse alcohol or drugs. So just think about when you do activities to promote the health and well-being of folks, how are you presenting them? The same thing for men. Men are not likely to come to knitting groups. Men are not likely, some, to join your book groups, but find those things that interest men and have the men breakfast and things with them. Other things are, support groups are very accepted in our culture, but only for certain things. It's interesting that if you have a small community and you invite people into a support group for grief, that will be likely to be accepted. Again, if you're going to have a support group for depression, a support group for alcohol abuse, likely not to come. But if you have a discussion group that begins to address issues like spirituality, spirituality can encompass all of these issues. Finances. We already know that somebody who's concerned about their financial situation may be susceptible or have a risk factor for suicide if they're worried about their money. So if you do something very positive on how to save money, great buys in our community. We had a program at one of the facilities where I worked yesterday on how to utilize coupons in CVS pharmacy stores to get more payback on your money. All sorts of ideas can bring people in to begin noticing who's coming and getting support for these folks, promoting health and well-being. Communication about loss. They may be better attended if you do these in a positive framework. Let me give you a great example of something I did a couple years ago. I gave a program called To Drive or Not to Drive. And nobody came to the program. Nobody showed up because it looked like I was going to take their license away or there was something wrong with them. We changed the title of the program to Driving Longer, Driving Better, and people came. So remember, as you're bringing up programs for people to participate in, it has to have a positive tack and something that isn't going to make somebody feel susceptible that people are looking at them. So what are activities with a purpose? In the beginning of the program, we talked about self-esteem, the desire to be respected, the desire to be needed. If somebody doesn't have that, does that take away a purpose for living? Well, teaching and tutoring gives people purpose. Fundraisers, maybe just to raise funds for the children of the residents for a scholarship. Maintaining community gardens. One great one is knowing that residents still want to help other people. Assisting other residents with shopping or appointments, those are all important things. So I want you to think about activities that give people a purpose. I want you to know that some of the activities that will not give people a sense of purpose are bingo. That doesn't give a sense of purpose. It is an activity, but not purposeful. So just think about those, and we have lots of other ideas for you, and please send me in those questions. I'm going to take a minute and see if anybody has any questions. For those of you that texted in the questions, let me give these to you. So, can someone have a hereditary propensity for suicide, genetically speaking? I can't speak to the question on genetically speaking, but I can talk to you about, we know that if someone has had a suicide in the family, that they have a higher risk factor for suicide themselves. But genetically, I wouldn't feel comfortable answering that question. I honestly don't know. But we can try to get you an answer. And I believe they have the person who sent that in, and I'll try to get back with you and get that for you. As a CNA, I see many instances of what appears to be depression in our residents. What if I appear to sound paranoid when I make mention of them? I want to tell you that's a great question. And as a CNA, you are there to be the eyes and ears for the people that you serve and for the nurses that you work for, but every resident that you see, and there are so many that are suffering from depression, that I don't think you are paranoid. I think you will know those residents better than anyone, and I think to be quiet and worry about how you look instead of how they work would be more of a concern for me. How do you identify and prevent passive suicide? And if this is what they want, why isn't it considered as an end-of-life decision? Wow, those are two wonderful questions, so let me answer those. How do you identify and prevent passive suicide? When we talk about passive suicide, this is weight loss because somebody is quitting eating. When we look at, is somebody dehydrated, that they're not drinking? What are the signs of dehydration? If you feel that you see weight loss, and that can come up when we do our monthly weights, and this person might need to be put on weekly or daily weights, we need to look again at dehydration. When you're doing fluid rounds, are you seeing that the person isn't drinking? Are you just refilling a water pitcher? Is the person trying to get you to leave the medications at the bedside? That would be ways that you could identify that a person was trying to develop a plan for themselves. And we talked about not leaving those meds in a room and not giving people access. And we know in assisted living, people have the right to administer their own medication. But we also have the responsibility to know that they can do it safely and that we are on top of how much they're taking their meds and are they taking the right amount. That's our responsibility. So those are all ways that we could see that. The next one is, why isn't it considered an end-of-life decision? The reason is because for an end-of-life decision means that somebody should have a diagnosis of a terminal illness, that they're making that decision, and they're making it as an informed decision, that we know that they have recognized what's available to them. And when you go into hospice or you work with people in palliative care, they spend an inordinate amount of time determining if that person is making a rational decision based on information that they can make that decision carefully. Not that this passive suicide is because they're suffering from depression or as a side effect of a medication that could be disturbing their balance and homeostasis. So these are all important questions and good ones, let me say. Okay. This is from Mary about my nurse. I think one of our residents is depressed, and I tried to talk to the nurse about it, but she doesn't seem to listen. I'm worried about the resident. And you should be worried about the resident, Mary, and it's a shame that the nurse isn't listening to you, because as a nurse, I can tell you, I know we get busy. I know that our lives sometimes just seem overwhelming at work, but this is one of the most important things that we have to do is to listen to you. And I would tell you this. If I worked in a facility that had an MDS nurse, I would go to the MDS nurse. If you are in a skilled facility, there should be an MDS nurse. There are other people to talk to besides the nurse. If you have a chaplain, you can talk to the chaplain. You can talk to a social worker. You can talk to an administrator. You can talk to so many people in your organization, but the MDS nurse has the ability to go in and do one of the depression tests. I would tell you the social worker can go in and do that. Even the activity people to see if they can start engaging. Are they seeing it too? Getting a number of people together to look is what we call an interdisciplinary process. And so I encourage you not to try to do it on your own and not to depend on one nurse. And maybe if the one nurse you told isn't listening, maybe another nurse would. But don't give up and keep trying to bring attention. This is from Sandy. How do I tell if someone is depressed if they are very quiet and don't talk much anyway? Are there any specific questions I could ask? And yes, there are. And I would tell you to go back to all the different tests that we have, and they're in this toolkit, but you can look up any one of those and Google them. And so, like if you look at the depression scales, those are all questions that are asked of people. Very easy to ask, very simple, and those are ways of even opening dialogue. And they're good questions and questions that aren't threatening to people. So I encourage you to use those determinants for depression. So go back and look at those on the Global Depression, the Cornell, the Beck, all of those. And there's so many more, but those are good ones. So that's a great way to begin to know what questions to ask of very quiet people. And those very quiet people, it's very interesting, when you begin to ask those questions and open up to them, they're very anxious to talk to you usually. That will be a sign in and of itself. Know that you can take these programs and set up a projector to a laptop, and you can show it to your entire group of staff. We encourage you to do that. We want you to use this. We want this information out. So we look forward to our next part on what we can do to prevent suicide and what to do if it happens. So again, thank you for joining us. We'll see you again soon. Bye-bye.